My topic is T-guided TAVR in a patient with severe renal dysfunction. So basically, it would emphasize on how would you minimize the use of contrast in a chronic kidney disease patient or a patient going for TAVI and having renal dysfunction. So introducing to the topic, approximately somewhere between 3 to 50% different literatures have quoted that patients undergoing TAVI can have acute kidney injury, and on an average 20% of the patients undergoing TAVI can have acute kidney injury. And this is of multifactorial etiology. And if a patient is having chronic kidney disease with severe renal dysfunction, their long-term outcomes are very gloomy if you have not been careful while performing the procedure. So the mortality has been seen to increase if contrast has not been handled carefully. And most importantly, the factor that you can take care of is the contrast-induced nephropathy, which is the only most important modifiable risk factor for these patients for better outcomes. And so for that, whether it is the pre-TAVR workup or whether it is the procedure or the post-procedure follow-up of these patients, you have to be careful that you don't subject their kidneys to offensive drugs, especially the contrast and the techniques of the procedure also. So this is an overview of how would you do a TAVI with a zero contrast or minimal contrast, I would say. Zero contrast is absolutely feasible, but in some situations, you are forced to use a very small amount of contrast, which is like, would be fine if you have followed the nephroprotection measures prior to taking up the patient, whether it is for the pre-TAVR workup or whether it is for the post or whether it is for the procedure. So you have to stress more on non-contrast imaging techniques, and non-contrast imaging techniques would include a simple transthoracic echo, a transesophageal echo, and moving to the CT, it would be a non-contrast CT of the peripheral vasculature, the access vessel delineation by non-contrast CT, and then in some centers where carbon dioxide angiography is used, they also use that for doing a carbon dioxide angiography of the peripheral vasculature. Then you have to be careful during the procedure when you are doing how to take help of imaging and the surface markings to whether it is for the vascular access or whether it is positioning of the valve and deployment and so on and so on. So you have to be very familiar with the imaging. And these patients, if they are very high risk, there is no harm. If you are purely subjecting to a T, then it is good to do these patients under general anesthesia, where T can be done very comfortably and the sizing can be rechecked at the time of doing the procedure. So these are some of the images how you will get on a non-contrast plain CT of the iliacs and femorals that would show where the bifurcation level is, what is the distribution of calcium, and then you can hang these pictures when you are doing the procedure, and just on the surface under the fluoro you can take a direct puncture of the site of access. Similarly, these are some images. Of course, these are not from my center. These are some DSA images of carbon dioxide angiography that are used for peripheral angiogram, and that can give us an idea of the vessel size, the bifurcation level, and we can take the help of these images during the access. Similarly, cardiac magnetic resonance imaging of various kinds. Those details are not to my knowledge also very much familiar with, but these are said to be superior to the non-contrast CT, or at least non-inferior to the CT, where you can assess the size of the annulus, you can see the safety of coronary arteries, the heights, and the sinus of Valsalva. Every measurement that you do by the gold standard test of contrast enhanced CT, you can do it with a CMRI as well. And these are some of the T-guided images, 2D T is good and 3DT is superior and almost said to be at par with CT and contrast CT imaging techniques. Uh, these are some of the T views in which you see the aortic annulus and the aortic and the LVOT and make different measurements. The lower frame, the lower panel shows the anteroposterior and the mediolateral annular diameter. So you have to make multiple measurements actually of these images and then see for the average as well as the largest size, so that you are neither undersized nor oversized, ending up with paravalvular regurgitation like things. These are some of the multiple views of 3DT, which how one has to take the size of LVOT, the annulus, and the SOV, and then you have to take an average and decide about the size of the valve that you are going to choose. So, and this is the next level of 3DT imaging, which is called multiplanar reconstruction of images, where you have to, where at one point of time you will get images in different views, and that helps to assess the size, the safety of the coronary arteries, as well as the when you are deploying the valve, positioning and deployment also. If you have a multiplanar reconstruction of images, you can do the work better. This is an example of how you assess the left ostium height and right ostium height on a 3DT reconstructed image. This is again a non-contrast coronary CT, which shows the height of the coronary arteries, the calcium on the coronaries. They show us where the coronary arteries are, and you can measure and you can make sure that your coronaries are safe. Similarly, when you come to the procedural part, the access doesn't need to be taken anymore by injecting a contrast as it was done in the beginning. Now ultrasound guided puncture is very easy. You can see and identify the segment of the common femoral artery where there is no calcium, and you can do an anterior puncture. And yesterday, as Dr. Kapadia was showing, that they have a CT display of the image on their screen while doing the procedure, they can straight away take the puncture even without an ultrasound guided access method. So this would eliminate the use of contrast while vascular access is done. And this is an image which shows how the device, when you have taken in and with a multiplanar reconstruction, two views, the LAX view and the short axis view, you are seeing both of them, and you can see the device, how and where you are positioned, whether you are too deep or whether you are appropriately placed just below the annulus. That can be assessed. And then these are some of the other things that your transesophageal echo will help, especially if you have taken these high risk severe renal dysfunction patients under general anesthesia. At every step, whether you are parking the wire or the pigtail in the LV cavity, sometimes you can get entangled in the subvalvular mitral apparatus. There can be mitral regurgitation, there can be distortion of the mitral leaflet. All these things can be seen intraprocedurally by the T guidance and does not need any other imaging modality to make the procedure go smoothly. Now coming to the positioning, this is an example of a patient where the balloon expanding valve was deployed without the use of contrast. You can see three pigtail catheters are in the aortic sinus. So either you can take all the three pigtails one from the non-axis side, one from the radial, and the third pigtail can be taken from the same side as you are as that of your access vessel from a puncture point which is below the main axis puncture site. It can be also done with two pigtails, or it can be sometimes done with the help of coronary wires also. So various people have used. So you put the one of the pigtails in the non-coronary sinus, and the other one goes into the right coronary sinus, and the third one can be in the left. So you either follow the right cusp rule and bring them all in one line in the coplanar view, and that then you pull out the right and the left sinus, the pigtails, before deployment and before final positioning. So this is a very interesting way to ascertain that your positioning of the device is appropriate and how deep or how shallow you are. Then similarly, this is an example of a self-expanding valve, where we just took the help of calcium on the valve and at the annular level. This was a highly calcified patient anatomy, where the non-coronary sinus had a chunk of calcium. So that served as the marker for pigtail, and the pigtail was there. And in these self-expanding platforms, we just park the band of the device at the level of the mid pigtail, and so you don't need to do any check. You are well below the annulus, and in the cuspal overlap view, if you are positioned well below, and your marker band on the device, which will help where to start with, which is usually the mid part of the pigtail, and then you start unsheathing and finally deploy it without even a check of contrast, or maximum maybe 5 ml of contrast you can give. Some people, what they do is that they pace at say around 120 or 150, so that the heart rate is slow, and even a 5 ml or a 10 ml contrast would be adequate enough to ascertain that yes, your device is in the right place. So that is an option you may use or you may not use. That is the place where the role of the T multiplanar reconstructed image will help, that you won't go for giving a ml of contrast also. So that's how we finally deployed the device, and this was zero contrast. This is an example of a picture showing where the patient ended up having a significant paravalvular leak, but the retrospective analysis which was done was found that the imaging was not done appropriately. The valve was undersized because the different multiplanar views were not assessed properly, and so the operator ended using a smaller sized device and had a significant paravalvular leak. So one has to be very familiar with T, and generally it should be done under general anesthesia, and on the day of procedure also it should be ascertained that what size you have chosen should depend upon multiple measurements of the aortic annulus in different views. Coming to my summary, the teaching points are: zero contrast TAVR is a feasible, safe and effective option in patients with severe renal dysfunction. CMR, 3D TE are promising alternatives to gold standard contrast CT, which is in practice routinely. Procedural guidance strategies employed include ultrasound guided and carbon dioxide angiography for determining vascular access, and fluoroscopic guidance using pigtails, coronary guide wires, and transthoracic or transesophageal echo to deploy the valve. Thank you.